Hello, I'm Dr. Caitlin Chambers. I'm a sports medicine orthopedic surgeon and an assistant professor of orthopedic surgery at the University of Minnesota. Today, I'll be taking you through the knee exam in preparation for the Bellringers workshop. Examination of the knee should begin with inspection for any evidence of ecchymosis, swelling, or atrophy. A special test for swelling involves sweeping from the medial side of the knee distally to proximally to encourage any fluid to come up to the suprapatellar pouch, then pushing on the lateral aspect of the knee gently. If there is an effusion in the knee, this will demonstrate a fluid wave visible on the medial side of the knee. Next is palpation. These next 3 slides demonstrate drawn out landmarks and surface anatomy that you can feel free to pause to reference later. Here you can see palpation of the tibial tubercle, patellar tendon, inferior pole of patella, lateral border of patella, medial border of patella, medial joint line from anterior to posterior, lateral joint line from anterior to posterior, lateral femoral epicondyle, fibular head, medial femoral epicondyle, and medial tibial insertion of the MCL. Range of motion testing is next performed with the patient laying supine. First, you can check passive extension of the knee, which is 0 in a normal knee, although many patients can have hyperextension as shown here. Normal knee flexion is 130 degrees on average. By placing a hand over the anterior aspect of the knee during passive range of motion, you can feel for patellofemoral crepitance or cracking and popping sensations. Active knee extension should also be observed to evaluate for any disruption or weakness in the extensor mechanism, which consists of the quadriceps tendon, patella, and patellar tendon. Ligamentous testing should next be performed to assess for any laxity of the cruciate or collateral ligaments of the knee. To review, the anterior cruciate and posterior cruciate ligaments resist rotation as well as anterior and posterior tibial translation, respectively, while the medial and lateral collateral ligaments resist valgus and varus stress, respectively. The ACL can be assessed with the Lockman test, where the knee is placed at 20 degrees of flexion, then, as shown here, the examiner's left hand places an anteriorly directed force on the tibia, while the right hand stabilizes the femur. This is compared to the contralateral limb and graded based on the amount of increased translation and presence or absence of a firm endpoint, as summarized here. The anterior drawer test for ACL laxity is performed with the knee flexed to 90 degrees. The examiner then pulls an anteriorly directed force on the tibia with a positive test indicated by translation of more than 10 millimeters. Similarly, the posterior drawer test for PCL laxity is performed with the knee flexed to 90 degrees. The examiner then pushes a posteriorly directed force on the tibia with a positive test indicated by translation of more than 10 millimeters. A posterior sag sign can be seen in the presence of a PCL injury, with the tibia resting posterior to the anterior aspect of the distal femoral condyles at 90 degrees of knee flexion. LCL laxity is assessed with a varus stress test, with the knee at both 0 and 20 degrees of flexion, placing a varus force which pushes the ankle medially to recreate a bow-legged type alignment of the limb, and is graded based on millimeters of lateral opening. MCL laxity is assessed with a valgus stress test, with the knee at both 0 and 20 degrees of flexion, placing a valgus force pushing the ankle laterally to recreate a knock-knee type alignment of the limb, and is graded based on millimeters of medial opening. McMurray's test is performed by dynamically hyperflexing, then extending the knee while applying a varus stress, then repeating this while applying a valgus stress. A positive McMurray's test is seen with a palpable click at the joint line and may also be painful. This indicates a meniscal tear. The patellar apprehension test is performed with the patient's knee extended and muscles relaxed. The examiner's fingers push the patella from medial to lateral, and the patient is observed for any signs of apprehension or fear of this lateral translation, such as wincing or muscular guarding, indicating lateral patellar instability. Clark's grind test is performed by placing a hand just superior to the superior pole of the patella, then asking the patient to contract their quadriceps muscle. Pain with this maneuver is a positive test seen in the setting of patellofemoral arthritis or cartilage injury. This concludes the overview of the knee exam. Thank you.